The difference between low risk and high risk MDS is that when we consider low risk MDS, we look on the parameters like hemoglobin level and like platelets level. Also, we consider the percentage of blast. These are the cancer cell in the bone marrow. And we also check for the cytogenetics of the myeloid cells in the bone marrow. In order to calculate the risk, we sum all the parameters, and each parameter gets some kind of point. And if the patient, or if the sum is up to 1 or 1.5, then it is considered low-risk MDS. And if it's above, it is considered intermediate risk or high-risk MDS. So what risk are we talking about? We're talking actually the risk of progressing to acute myeloid leukemia. So if we can take a step backwards and see what MDS is, like Myelodysplastic Syndrome, then we deal with qualitative and quantitative defect in the bone marrow. It's like place that doesn't work well and puts out cells that don't act well. And on the clinic, we get a patient with anemia or thrombocytopenia or leukopenia. And the patient can present with the fatigue or like recurrent infections or like spots of purpura, which is small dots of bleeding. And that's maybe the only signs that something is wrong. And if we want to make a diagnosis, we need to do a bone marrow biopsy, which is like checking the main source of the place that the blood cells are being produced. Okay, and we look for the morphology of the cells, and we look for the changes that biological material has in the cells, like the DNA, and then we see also what lines are defected, like one line like just anemia, two lines like anemia and thrombocytopenia, or all the three lines. And as I said before, each parameter gets a grade, and when we sum the grade, then we consider a patient either he is low risk or high risk MDS. Okay, and then we consider what should we do. If the patient is considered low risk MDS, then we have a few options. If the patient is asymptomatic, then we can only just follow him. Follow up it can be like a 3 months visit to the clinic, and if he feels well, then we do nothing, just watch and wait. If the patient is symptomatic, usually the main complaint would be anemia, like fatigue, like shortness of breath, or anything like it. And then we should consider the level of anemia. If he is very anemic and he needs blood transfusion immediately, then we give it. But if the patient just mildly tired, then we can consider giving him like erythropoietin agent. We need first to check the level of erythropoietin in his blood. Usually, patient with low level of erythropoietin will be those that will mostly react to the drug. We have right now 2 or 3 drugs that we use, like alpha-poietin or derbapoietin, with mild differences in them. And we usually give this injection subcutaneously, usually once a week. And we need to give it a chance of at least 8, maybe 12 weeks before we can say that this treatment has failed. Usually patients manage well with this treatment and the level of the hemoglobin usually rises. If the treatment fails, then we need to consider a few things. Does he need blood transfusion or has the MDS progressed? Another concept that we need to consider is what are the cytogenetics changes that we found in the bone marrow biopsy. There is a special entity which is called 5q minus deletion, isolated 5q minus deletion entity, and for that we have a special drugs which is called Lenalidomide, okay? And it has been shown that specifically in that group of patients, this is the most effective treatment. We talk about a pill, taking a pill once a day for 21 days, and then we're having a break for 1 week. And there was research that proved a great improvement with this drug. It is approved in the States and also in Israel, and patients tolerate it very well. If the patient deteriorates or the treatment is not sufficient enough, then we have to consider progression. And when I'm talking about progression, I mean that the level of the risk has progressed from low risk to intermediate risk or even for high risk. So how can we know that besides the clinic? First of all, we need to recheck the bone marrow, to do a bone marrow examination again, and to see, to look for the blast. The percentage of the blast together with maybe new cytogenetic changes or acquisition of new mutations set the patient to a higher level of risk to proceed to leukemia, to acute myeloid leukemia usually. And then we have another options of treatment. I think the most notable is the hypomethylating agents like I5-azacitidine, Vidaza, or the citabine, which is Decogen. These treatments usually modify changes around the DNA and cause genes that can fix the DNA in order for the cells to become normal or less cancerous. These kind of treatment usually can't be stopped. I mean, we use them as long as the patient reacts. We have special considerations for patients who are young. And when I'm talking about young patients, I'm talking about patients until the age of 60, no offense to anyone. And then we consider what we call bone marrow transplantation. Right now, this is considered the only treatment that can give a full cure or full chance of cure to the patient. Having said that, today we know that we have some new drugs that might change this consideration. We know that patients with MDS gain some mutations that are from the world of myeloid leukemia. And we know that there are treatments, there are medications that are under investigation that are being checked for changing the paradigm treatment for leukemia. There are researchers that check these drugs also in the field of high-grade MDS. And maybe these new combinations will change the progression of MDS, of high-risk MDS, to go to AML.